This is a little bit of an update on our own retrospective data set and a little pre-taste of the Saturn database that we were going to present at the AU next week. So we'll have to be a little bit more patient about it. These are my disclosures. Relatively active, so Proctor advisory meeting attendance for Boston Scientific, also for Neomedic, investigator in the Prospect trial, which is a randomized controlled trial of the U-strap device from Cousin versus the AMS. So I'm happy to participate in a randomized controlled trial in our field, and then I'm part of the steering committee of the Saturn. So I'm going to talk about treatment of male post-prostatectomy incontinence, and as you all know, there's unfortunately not too much high-level science in this field, so I'm going to talk about the treatment algorithm, and by definition this is what we do, and I'm sure that we will have some discussion about some other habits in our institutions or maybe some other devices that are implanted, and I'm happy to discuss about it on the course of the presentation. What's true for every post-prostatectomy incontinence patient is that these all have the same profile. They've been there already, they already had the surgery explained, telling them that there will be no complications, but still they suffer iatrogenic incontinence, mostly accompanied with erectile dysfunction as well. They all have a long life expectancy. 5-year survival of prostatectomy patients more than 95%. And so quality of life is important. They have some expectations, what they want to do with the rest of their life, and so I think it's important in this field to involve the patient in the decision making. I think everyone will agree with that. And unfortunately, we don't have high quality data. So it's hard to really counsel your patient with appropriate figures. And so I'm going to start off with a case, which is a very typical case. 71-year-old man who had a radical prostatectomy, robotically assisted for a significant prostate cancer about 5 years ago. And at the oncological level, everything is safe. So he's fine, he's happy, he's safe. But his main complaint at this moment is urine loss. And this is specifically during certain activities like gardening, hiking. He never has urine loss at night. He can actively interrupt the stream. He's got a good bladder volume, no urgency. And the problem is getting worse over time. And he's still performing his pelvic floor exercise. So I think this is a very typical case. Everyone sees it in daily practice. And so the first question is, do you need any additional investigations? Who would perform anything? Or can you already, with the data we have, can you already suggest a treatment? Yeah?
I will do cystoscopy to see how the sphincter works, if there are no strictures, and if there is any coaptation.
Yeah, it's coaptation. Would you cystoscope every patient if you plan to do a surgical treatment?
Yes.
For everybody? No? Kyle, no?
No. We do video urodynamics because in the law it is clearly that if you want to implant an artificial sphincter, you need to exclude vesico-urethral reflux, stone disease, and with the video urodynamics you can have a fractional radiography, so you will see the urethra.
So if you would have a good video dynamics, that's enough for you?
That's the only thing I would do.
Would you evaluate coaptation cystoscopically or no? So there are some differences. First thing I do is, probably everyone will do this, but you just don't talk about it now. Voiding diary, just to have an objective measure of the problem. And summarizing here, he's got a mean loss of about 175 milliliters, and he uses 2 to 3 pads a day. And then I agree with Karel, we also perform urodynamics, not video urodynamics, I must say. In between brackets to confirm the diagnosis. Does anyone have an idea what percentage of patients does not leak on urodynamics prior to incontinence surgery? I had the data from the Saturn trial. I guess 10%? More. There's a catheter inside. 30? Better? So in the Saturn database, it's about 40%. 40. They don't show any leakage on urodynamics. Still, if the patient tells me he's leaking, I tend to believe him. So to confirm the diagnosis in the more than half of patients. And then patient counseling, I think everybody will agree with that. If you find a low systometric bladder capacity, certainly if they have urgency or frequency, we can counsel them that they will have that after the surgery as well. And we might counsel them that they still will need medical treatment after any surgical treatment of stress urinary incontinence. And then as Kyle addressed, I think we need urodynamics by law in Belgium to get reimbursement. I also do cystoscopy. I must say that I also cystoscope every patient prior to implant. First of all, as Katrien said, to exclude any anastomotic problems. And secondly, to evaluate residual sphincter function. And that's specifically in the sling candidate, and I think the patient I suggested first was a sling candidate. What does this mean in the sling candidate? Actually, this is a copy of the text by Reder. This means the dynamic ureteroscopy in lithotomy position with mid-perineal elevation behind and parallel to the membranous urethra. And this is what we call the passive coaptation of the sphincter. And it should be from a certain length, 1 to 1.5 centimeter, although this is very difficult and very subjective, I think, to appreciate. And I think I have an example here. So this is urethral compression. You push on the urethra, and the second move is coaptation test. This is more posterior to the urethra and parallel to the urethra. And so I'm going to try to show this on screen. I think that's what you want to see. You want to see the sphincter contracting and closing off completely while performing the coaptation test. To be honest, I always ask my patient to do this actively as well. So first I ask them to do an active coaptation, and then I do the repositioning test. And when I'm happy about the amount of closure and the length, then I feel more confident that a sling could have a good result in this patient. So I think in our case, he had good coaptation, he had his investigations, he had a good bladder capacity. Still, even if I think he's a good candidate for a sling, I will counsel him for a sphincter as well. I will give him the pros and the cons of both techniques, and he will have the opportunity to choose together with me. And also, obviously, in Belgium, we have to explain that the sling costs, or the advanced sling that we will propose, they will cost him about 1,700 euros, while the sphincter is free of charge for the patient. And so this is a shared decision process. And he opts for sling surgery. And I think that's also a common choice. I'm not sure if it's the experience of everyone in the audience. First of all, what's a good, I'll come back to that later, what's a good candidate? This is a summary. I think he needs to have a moderate amount of urine loss, not too much. Good sphincter coaptation, so the sling only gives support to the active sphincter mechanism, and adequate bladder capacity. And we know that they probably should not have had radiation therapy, or they should not have had treatments for stricture disease, because that will diminish the results.
What are the limits about amount of urine loss? Or do you need 150, 150?
That's a good question. I don't think there is a straight answer. I think here you enter the shared decision process with your patient. If your patient has all factors that are good, ideal, if he didn't have radiation, no stricture treatment, he's got a really good sphincter coaptation, he can interrupt the stream, but he's got a larger amount of urine loss, I think I would be happy to offer him a sling. As you will see from our own retrospective data, the strongest predictors of failure are the red ones, and they are correlated strongly with failure, while the other ones are probably more weak. And I think this has been shown in several retrospective cases. Unfortunately, not too much prospective studies. So what if he had radiation treatment and all the rest is the same, even the investigations, he has good coaptation. And he's actively asking sling surgery, because this happens often in my practice. There was a very interesting retrospective chart review, again retrospective, but this was a group and they checked the charts of patients, and the institutional habit was with these cutoffs, if they had a lot of urine loss, more than 400 grams, they were counseled actively for a sphincter. If they had mild, less than 100 grams, they were told you can have a sling. And in between, they told the patients, well, you can choose, you have good chances with both of them. So what happens? If the surgeon advises a sphincter, then about 30% still goes against the advice of the surgeon and wants a sling anyway. If the surgeon advises a sling, they follow him 100%. And if the surgeon tells the patient you have both options, then almost all patients go for the sling. And I think this is what I feel as well. If the patient has a choice, I think they prefer not to have manipulative device in the scrotum and no silicone. Good.
The study that was performed, maybe it was reimbursed there. In Belgium it's not reimbursed, the patient has to pay 1,700 euros. Does that make a difference?
Probably it will, although that's not my personal experience. I think patients are, first of all, willing and happy and able to pay 1,700 euros. Secondly, if they have insurance, often the insurance does cover the sling. As long as they write a letter and they write that this is the consequence of oncological surgery, then it becomes a little bit more easy. I think it works.
After a certain time, after 1 year, or doesn't matter?
For the sphincter, by law, we have to wait 12 months. For the sling, there is no clear reason. So I personally, if they want it, I will start offering it at 6 months.
Is it indicated in the study how they counsel the patient? Because it all depends on how you sell what a sphincter is and what a sling is. No, if
It is indicated.
first tell the patient that a sling is better than a sphincter, but they should opt for a sphincter anyway.
Well, in the materials, and that is written that they give a very balanced explanation. But I agree with that. Yeah.
In times that slings in women are questioned, what do you think about slings in men?
I think I'll come to that later when I present our data, because that's the excuse of all these slides to give a little bit of our data. I think it's another story. It's a totally different story. We don't have the same complication rates, certainly not compared to the prolapse meshes, and even not compared to the incontinence meshes in males. So, talking about it, this is our retrospective series, so we analyzed the data from 11 years implants, in total a little bit more than 200 patients. And what was interesting about this series was that we had somewhat more than half were ideal candidates, and the rest were candidates that had some risk factors for failure, like 1 in 5 was irradiated, 13% had stricture treatment prior to implant, and a big portion also had a urodynamic study that was showing the user overactivity. We started using the advanced, and in March 2011 we started using the XP, and from then on this is a consecutive series, first advanced, then advanced XP. Still the majority in the early days were open, but the new patients all had robotic assisted radical prostatectomy and sometimes some other surgeries, and also a good mix in rate of incontinence. And these were our definitions. So this is a retrospective series, so we didn't always have the exact number of grams, but if we had the grams, we used it, and if we had the number of pads, we used that as well. Nothing special, so age approximately 70 years old, well fed but not fat, and they all suffered incontinence for almost 2 years and longer, and the mean or the median was 2 pads. And they had quite a reasonable cystometric bladder capacity, but with some variation. So our definitions of outcome: totally dry is 0 pads, so this is actually what we should strive for. I think before surgery, before radical prostatectomy, in general, men don't wear pads, so that should be the goal. Social continence, to compare with other studies, 1 or less pads a day. And then failure was reduction of pads of less than 50%. Why did we take that measure as well? Because a lot of sling studies take success as a reduction of 50% of pad use, which is a very light definition of success in my opinion, but still then you can compare to other series. We did univariate analysis to check the subgroups, and then multivariate analysis with regression models. And then we had short-term, first 3 to 6 months follow-up, and the last follow-up at approximately 1 year. And so if you look at this, very interesting, the ideal group at last follow-up has an 80% social continence rate, and you see that when they have severe incontinence, which means half a liter or more, it reduces 50%, and irradiation and stricture disease is even a worse predictor of failure. These are univariate analysis. A totally dry rate, even in the ideal group, is approximately 50%. So wearing 0 pads, 1 in 2, not more. And then if you had stricture treatment or irradiation, I think you can almost forget about being dry as a goal. And as long as the data makes prediction possible, because our numbers are not really high, but still we have some patients with longer follow-up, you see that the effect, certainly in index patients, seem to remain over time. And this is probably one of the most interesting slides, also to answer your question, Koen. The highest predictors for social continence is irradiation with an hazard ratio of 3.4, so this is the strongest predictor of failure, and then also stricture disease, but also the user overactivity on urodynamic studies. So I think if you find these elements in your pre-op situation, you could explain your patient that he is in diminished risk of achieving social continence. And for the dry rate, the association is less strong. Funny thing is, if they leak at urodynamics, this is associated with a lower dry rate. So if they don't leak at urodynamics, you have a better chance of success. And I think only these two were significant for dry rate. They didn't need one, maybe. Then we defined loss of effect. This is maybe a little bit tricky. This is the only thing where we could show a small difference. I didn't show all the data, but where we could show a small difference between advanced and advanced XP. So in general, there was no difference. The type of thing did not correlate with outcome. But we saw that especially the advanced XP had significantly less loss of effect versus the advanced group. But this was a univariate analysis. And you see that in the index group, this is moderate, about 10%, or first happy and dry, and then lose their social continence status over the next months. And in the radiation group, it's about 30%. So also there, even you don't even come to the social continence status, and if you achieve it, you might lose it subsequently. What is a typical complication? So we have a man, we have implanted a sling, we remove the transrectal catheter in the morning following surgery, and he cannot void well, he has got high residual volumes. We encounter this quite often, so we define high EVR as volume more than 200 milliliters or symptomatic. And we encounter this in 1 in 5 patients, which is a little bit higher than what's reported in literature. But in the vast majority, this solves spontaneously, and we wrote within the first month, because in the beginning we used to place a transurethral catheter, we sent them home for a week or 10 days, and then we saw them back. Now we put all our patients on intermittent catheterization. Because we have a reasonable figure, I explain this to all of them prior to the surgery. They start catheterizing themselves, and the majority stops on the 2nd or 3rd day after the surgery. So very briefly, if the swelling goes away, they can avoid spontaneously. And in a total group of 216 patients, we only did 2 transections of the skin. So this is very rare, less than 1%. So permanent obstruction is a rare occasion. And then the only strong predictor for residual urine was previous strictural treatment. So if they had strictures before, they're at higher risk of going into retention. And this is quite significant. So, in conclusion, in the ideal candidates, I think we can offer them an approximately 80% social continence rate. But when they have a lot of urine loss, losing at night, loses everything, history of stricture disease or radiation, I think we can maximum offer them 50%. And this is exactly what I tell to my patients. If they are willing to take the risk, if they really don't want the sphincter, and they accept a flip the coin success rate, and they are willing to pay the sling, you could do it, but the chances are quite low. Okay, so if the patient comes to you and his primary desire is to become dry, certainly after radiation treatment, I think everyone will agree now that we should offer him a sphincter. If he wants the best chance of success, this is what you should do. I think everyone knows a little bit of the history. Actually, we are already, or I was not, but the Urological Society is using this device since 1988 in an unchanged form. Only in 2001 they put some antibiotics on the device, partially, which is not really a big change. So it's in use for more than 30 years. And this is the best solution for patients with more urine loss that are good candidates and are performed by implanters who do a little bit of numbers. Why moderate to severe incontinence? I think even with the sphincter you should have realistic expectations. Currently I don't have my own figures, but here as well the dry rate, certainly on the long run, is not really very impressive. And it will land at about 60% probably. So I tell all my patients they will not be dry as a bone. You will use one pad, but it's much better than the diapers you're using now. And in our review that we did a few years ago, in 2013, we had a pool dry rate of about 40%, but you see there was a huge variability from 4 to 86%, and so most patients will carry one pad. They need to have good dexterity, good mental capacity, enough incontinence, and it should last at least 6 months and indulge in 1 year. I always show a demo at the outpatient clinic that they can touch it, they can feel it, and I think here as well, besides the investigations we did for the slings, I also always perform a urine culture prior to implant. Why do we say experienced implanters? This was an interesting study from Memorial Sloan Kettering, where you see that the complication rate goes down. If you do 5 prior cases in your career, you have a 24% revision rate. If you did 200 prior cases, it goes down to 13, so there's even no real plateau. What happens in real life? 60% of implants are done by surgeons that do only 5 cases in their career, and less than 2% is done by the really, really big implanters. And I think that only happens probably in the United States. But still, I think volume probably has an impact on outcome. And it still is the best solution. This is just a summary. The sphincter has the best success rate using stricter definitions, 0 to 1 pets versus 50% improvement in more incontinent patients and also in irradiated patients. So the sphincter still is, with the data that we have currently, the best solution. And we use it for a long time. In an area where there's not much data, I think this is a valid point. The price, everybody knows this, high complication rates. Unfortunately, all these slides are made by my own, in my own patient groups. So this is a chronic erosion. This is, you don't see this clearly, but there's a tubing coming out of the scrotum. And this is a ruptured balloon, mechanic failure. And in a pooled analysis, these are the figures, but again, you see a very large variation. So if you do the surgery, you have to be prepared to solve the complications as well. Then the last question, my patient enters the outpatient clinic and he says, I want to be dry, but I have a history of radiation treatment. Does this impact my outcome also for my sphincter? Again, we don't have high quality data, but we have one meta-analysis, and although it might be garbage in, garbage out, it does give us some figures that are interesting. For revision, they found a pooled analysis of almost 2,000 patients having about 580 having both radical prostatectomy and irradiation, and about 1,300 undergoing only radical prostatectomy. And for urinary incontinence outcome, for efficacy, these were the numbers, 11 studies. And what you can see as a conclusion that for revision rate, there seems to be a 1.5 increase risk ratio that favors radical prostatectomy alone. So yes, irradiation increases the risk of revisions in a pooled analysis of sphincter implants. And the same is true for persistent urinary incontinence with a risk factor of almost 2, so also the dry rate is worse after irradiation. And having said this, there is probably even a publication bias, or certainly in smaller studies there is even a favor for positive studies to be published, so the negative studies aren't even published, so I think probably results are even worse than what we think at this moment. Why is this? Because irradiation induces tissue changes in bladder and in other areas. And I think this is the last part. So if our patient had an implant 3 years ago and he enters with pain while voiding, what is the problem? Perform cystoscopy. Should it start by itself? So when your patient has pain, always perform a cystoscopy. So we already went to the bladder, it's here in the irradiated patient. And here we see some plastic. Unfortunately, so this is also a chronic erosion. So pain, it should not be painful. If it hurts, there is a problem, and you should go for cystoscopy and expand. Currently, we have a 7 registry, 8 countries. Our aim is to go for 1,000 patients with 10-year follow-up with patient-reported outcome measures, so at least we'll have some prospective data. And these are the primary endpoints, or the endpoints that we are looking for. We started in January 2017. And this is a nice current status. So you see that from all the implants for male incontinence in the participating centers today, still the majority, about 3/4, is sphincters. So this is still the biggest group. And then the second largest one is the advanced, followed by some others, variable, but smaller. And then from the sphincter, it's surprising to see that in certain centers they're starting to use some other devices, but it's still a small minority. You see the reflection about radiation treatment, that sphincters, about 40% has been irradiated, while in slings it's only 12%. And it takes a long time before people decide to have an implant. That means going up to 85 months median time before implant for a sphincter. So people tend to wait maybe too long before they decide to have an implant. So we were going to present the data. It will be in July, as I heard, so if anyone is present there, we'll see. So to conclude, I think you should preferably hold the slings for the index patients. Involve your patient in the decision. These are the successes you can promise them, so don't go too high in your promises. And I always warn them that they might encounter a self-limiting residual urine or retention. And actually the complication rate is very low. We did not do one single explant in this series. Zero erosions into our implant. So it virtually does not exist. And then the sphincter is the working horse of our incontinence surgery. Its results have not been matched by our devices, but the intervention, high intervention rate remains problematic. And I'm waiting for novel innovations to diminish this intervention rate. And then I think we can conclude by the data that we have is that irradiation reduces the success of all the implants. It induces irreversible tissue changes. And in slings, for sure, strong predictor of bad outcome, but also probably in sphincter, they do worse, both on revision rates and on continence rates or incontinence.